Hello everyone, my name's Ellen Thomas and I'm a trust grade at Torbay Hospital. Today I'm presenting on radiographs post-Hemiarthroplasty, are they needed? And I'd like to thank Hannah and Robin for the work on this project. Hip hemiarthroplasty is a common operation performed for displaced intracapsular neck of femur fractures. Post-op radiographs have been used to identify immediate complications requiring further surgical attention, including dislocation, cement retention, or periprosthetic fracture. Until March 2020, routine practice at our trust was to perform an X-ray on the table for all hip hemis, or failing this, a departmental X-ray. However, due to COVID-19, this was stopped to reduce patient contact with staff in line with infection control. We questioned whether practice should return to normal if these radiographs are needed. There's currently no guidance from NICE on post-operative imaging after hemi, and variation exists between orthopaedic centres. We also sought to find out how often we act upon these routine X-rays. Using the National Hip Fracture Database for our trust, we conducted a retrospective cohort study of all hemis performed from March to December in both 2019 and 2020, excluding periprosthetic fractures, and data included the review of clinical notes, imaging, and complications identifiable on an immediate post-op X-ray. The total number of patients for the study was 318. Post-op X-rays were obtained in 99% of cases in the 2019 cohort compared to only 15% in 2020, and the vast majority of those were performed on the table as opposed to in the radiology department. In the instance that X-rays were obtained in the 2020 cohort, twice as many of those were done in the department rather than using fluoroscopy in theatre. In the 2019 cohort, 6 patients had complications and only one of those occurred during their initial admission. 5 were dislocations and 1 was a periprosthetic fracture after a further fall. The dislocation that occurred within the same admission had a normal on-table X-ray. In the 2020 cohort, 1 patient returned to theatre due to post-operative infection for a washout and revision, and they too had a normal routine post-operative X-ray. Based on these results, no surgical action was required as a result of post-op X-rays taken during the admission. As hospital operations commence plans to return to normal and the constraints of the pandemic appear to be relaxing, we have considered other factors in reinstating routine X-rays, and there are several disadvantages. Firstly, and most importantly, is the radiation dose involved. Notably, a pelvic X-ray conveys the equivalent to 4 months of natural background radiation and an additional lifetime risk of fatal cancer of 1 in 30,000 per examination. Another factor to consider is time. X-rays in theatre may prolong the anaesthetic time of a patient, and after a trust audit, radiographers anticipate spending an average of 90 minutes attending theatre, with an average cost of £33 an hour, dependent on their grade. So where this cannot be done and patients have to attend the department for an X-ray, there's a potential risk to contribute to both post-operative delirium and also length of stay. The third disadvantage is cost-related. The cost of fluoroscopy in theatre is difficult to assess due to variations in time and radiographer, but using the average time of 90 minutes spent out of the department to obtain an X-ray on the table, it can vary from £40 to £120. So if we apply this to the 2019 cohort, the estimated cost was between £6,000 and £20,000. We acknowledge that this study is limited by its small number of patients. However, we conclude that routine post-operative X-rays following hemiarthroplasty, in the absence of clinical findings to suggest a complication, do not change the immediate surgical management of patients and come with both unnecessary radiation exposure and costs. I've listed some of the resources used, and thank you very much for listening.